Next, I'd like to talk about the adjustable gastric banding. There's two bands available in the US, the Realize band and the Lap band, and I think the science of it and my opinion of it is independent of which brand it is. With adjustable gastric banding, I'm going to redraw this part of it. The very top part of the stomach is essentially partitioned in a way that an artificial narrowing is created by placing a band to limit the flow of the food from the top part of the stomach into the bottom part of the stomach. Once the food passes just below the level of the band, everything that happens from that point on is identical to the normal anatomy. And I think the problem with the band is what happens at that level and above. The concept of the band had been that if we limit the size of the stomach with the amount of portion that the patient can tolerate, we can correct the problem of the obesity. And I think there's overwhelming amount of science out there that shows that obesity is not a disease of overeating and lack of exercise. Overweight patients don't gain a lot of weight just because they eat the wrong stuff and they're inactive. There's clearly a significant component of lifestyle and inactivity that plays a role into it, and I'm not discounting the fact that we've become relatively inactive and we're eating unhealthy amount of processed food, but in the scheme of the whole thing, they represent a relatively small part of the problem. Genetics, environmental factors, our exposure to certain processed food, independent of the amount of calories that we take, they all place a role into it. One cannot discount the importance of the stress in our life and so forth. But when it comes to the band, the notion was that if we can create an extremely small portion of the stomach and create an artificial narrowing, a patient would eat a lot less. They should theoretically not be able to eat anymore, and then they'll limit their caloric intake and absorption, and they'll result in weight loss. The outcome of the adjustable gastric banding has been proven to be anything other than what was promised to most patients. Now we know that the scientific data shows that the outcome of the adjustable gastric banding results in, at best, about 30 to 40% of the excess weight loss, and there are data out there that shows that anywhere between 25 to about 80-90% of the adjustable gastric bandings have to be revised, redone, or recorrected in one form or another. And this is not even talking about the complications of the adjustable gastric banding for patients that have persistent abdominal pain, nausea, vomiting, reflux, they develop asthma, and even worse, patients that have non-resolution of their comorbidities, the problems that prompted them to think about weight loss surgical procedures. So going back to the adjustable gastric banding, as the food enters from the esophagus into the stomach, there's a 1 or 2 or 3 ounce stomach at the very top part of the stomach above where the band is placed. Food will sit in there and it will trickle down through a very narrowed opening created by the artificial narrowing of the band. As the food enters the stomach, everything happens in a normal fashion. What's important to realize is the problem is with the banding is the patients have this conflicting sensation of continuous hunger with a sense of throwing up and significant pressure, and that may be extremely distressing to most patients, least of which is no one explains to them why they're experiencing those problems. If we go back to the normal anatomy, and as we talked about the sleeve and the duodenal switch, there's a set of hormones up on the top part of the stomach, the ghrelin hormone, that regulates our perception of the hunger. With the adjustable gastric banding, the part of the stomach that produces the hormones, most of it is below the level of the band. So the narrowing that's created and causes the patient to have that full feeling is because of the fact that the food sits above the band, but the empty stomach is still below the band. So it's not uncommon to have patients with adjustable gastric banding that have the sensation of extreme fullness and pressure and hunger at the same time. My opinion of the adjustable gastric banding, as has always been, that I think there are much better alternative procedures available out there that produce much better outcome long term with superior weight loss, much better odds of resolving the comorbidities without the complications of associated with the adjustable gastric banding. There's a large part of my practice that involves revision of patients that have had adjustable gastric banding. For one reason or another, it was promoted that this would be a quick solution to most of their health problem, and the list is that their problems have not been resolved, and in a majority of the patients, they have developed other problems with their GI tract because of the band that's been placed. Those patients are ideal candidate to have their procedure revised from band to the sleeve, and in some cases from band to the duodenal switch operation. Both of those procedures can be done laparoscopically. In majority of the cases, they're outpatient, but again, these are things that need to be evaluated in individual cases.